All right, welcome to the Positive Deposit Podcast, where we transform minds to change lives. I'm your host, Presley Nelson Jr., and I'm so excited about this episode because we usually talk to patients or cancer survivors, and we have a live breast surgical oncologist, one of my close and dear friends, especially because we went to Howard campus pals, and so this is a friend, more than a doctor. And so I'm so glad to have Dr. Shaunda Grisby. And so before we get started, I know I wanted to give you the time to kind of introduce yourself, and then we'll jump right into this dope conversation.
Well, hello, everybody. I'm Shaunda Grisby. I am, as Presley said, a breast surgical oncologist. I've kind of been all over the globe. Again, obviously from California, but I went to school in DC, the real HU, as everybody knows.
Oh, yeah.
And of course, met Presley, and we've kind of been, intertwined ever since. And again, it's one of those things where you end up where you end up. And here I am in Louisiana, where I have, I guess, stake my claim into the breast world out here, and just trying to help people make it through things that are tough.
So. Awesome. Well, welcome to the show. So I'm gonna jump right into it. When did you know you wanted to be a surgeon? Like what? Because before, I know you were doing your thing at Howard, biology, I'm assuming, but you took it to the next level. What gave you that drive?
Honestly, I think my first thought was that I'm just going to be a doctor, like whatever doctor that meant. My parents will tell people, she just one day woke up and was like, I'm going to be a doctor. We don't have many doctors in my immediate family, so they have no idea where that thought came from. And honestly, I don't either, but I think I just kind of set out on that path. And I kind of found through life that I knew I had to be doing something with my hands, I guess. I like to get my hands into things and build and play and tinker. And so I think it's kind of how I segued into surgery, because I thought, well, I actually enjoy painting. I enjoy doing certain things. And so that's how surgery became a part of what I thought I could do, because I think of surgery as art, I guess. And so that's kind of where I approach every person, every patient that I'm talking to or dealing with. And in the operating room, it's art. And no matter what you're taking out or remove, what you have to leave them with is what you're leaving your mark with. And so that's pretty much, I think, how surgery kind of appeared in my mind, I guess, throughout
where'd you go to med school?
Undergraduate school, Howard, and then I ended up going to med school at the Charles R. Drew. It was a combination program between Charles R. Drew and UCLA, and we were essentially a part of both programs. What Charles R. Drew brought to the table was more focused on underserved populations. So that's kind of where my niche always is to try to help and to impact the lives of those who are less fortunate or who don't have as much access. And you get all the same trainings as our fellow UCLA students, but we had to do other things. We had to have a thesis paper, we had to do some other outreach in the communities. We went to different areas that were probably not as flourishing to do some of our rotations. And so that has always been instilled in my mind. That was part of the reason why I went to that program, because I knew I was going to still get my UCLA education, but I wanted to be still focused on those who can't help themselves. And of course, that's kind of been my mission ever since.
Wow. And so were there any other schools that, you were applying for, or and before, you picked this school to pursue this journey?
Mm-hmm. Absolutely. I think, truthfully, I interviewed at quite a bit of schools all across the United States. As people know, I have no problem going from one place to another, making friends and surviving, I guess. But I interviewed in schools in North Carolina, like Duke, and I interviewed some other schools, in New York City, Dartmouth, like pretty much all places. And quite frankly, I actually went into pretty much every school that I interviewed at, which was nice. So I actually was able to kind of select where I wanted to go. But it was I ended up selecting this program because of some of the added features that it had, some of the expertise, and the style of teaching. I guess different schools have different style. Like for example, University of Southern California was more of classwork, 9 to 5. Every class was a structured class. But with UCLA's program, it was more of, you're going to focus on a system. So everything was systems based. So they talked about this in the system, and you weren't necessarily sitting in class from 9 to 5. You had your structured lectures 2 hours a day. You had these different types of hands-on things that you were doing, throughout the rest of the day. So it kind of broke it up, and that was what I liked that. And a lot of it's still self-directed learning though. So you weren't it wasn't like still have to go and do your own study. Like no one's necessarily telling you what to do. But to me, that was much more functional for who I was, I guess.
Yeah, I think that's dope that, obviously your hard work paid off because, I mean, I know it's not easy to get into every school that you interview for, so, I mean, you're a special individual. Hard work pays off. And so that's dope. Were there any challenges? Like, you picked your school, this is a different lane as far as actually working with the underprivileged and things of that nature. What challenges did you go through while you were attending and doing like your residency?
Yeah, so med school challenges weren't too bad. I think I put my best foot forward every rotation. I could tell you I probably didn't like every rotation that I went through, and I knew surgery was probably where I was going to go. But my main goal always was to make sure that people didn't know I didn't like the rotation or that I wasn't that interested. But not that I wasn't interested. I shouldn't say that. But it was just more of I just knew where I needed to be. But these other rotations you have to go through because you need to learn these things. So truthfully, that wasn't really so bad. It just more of just making those points, but still learning and taking an active role as a student to learn everything you can from each rotation, because each rotation has something to give. And I think that's what people need to realize. So today I find some of our med students kind of come around and you're like, oh, I don't really want to do surgery, but I kind of feel like you still need to understand, because if I'm going to call you for a consult as a family medicine physician, you should still know some of the things that I want you to do and why. And so therefore it makes you better as a physician to know how other physicians do their job, I guess. In residency, yeah, I mean, I think so, but sometimes people don't like to work as hard these days. But in residency, I initially started out in a STEM on purpose. I think I wanted to gain much more hands-on experience from the beginning. So I think that is a very important factor when someone's choosing where to go to residency. The bigger institutions are great. They have a lot of notoriety. Everybody knows their name. But you're like, there's so many different specialties and so many different people involved in those specialties that you don't get to be involved. So I tell people I went to a smaller program that only had general surgery residents and internal medicine residents. But we had every kind of surgeon. So we had orthopedic surgeons, neurosurgeons, urology, like pretty much OB-GYN, everything that you would need. And I got to participate in all those surgeries. So it wasn't like I had OB-GYN residents who would do and deliver babies. I did C-sections, delivered babies, did ectopic pregnancies in the middle of the night. I think I've done knee and hip replacements, patella tendon, so I've taken out kidneys, done all kinds of things.
So you got a little bit of everything, like you.
Right,
so don't believe the hype and the big name and things of that nature, because those smaller schools actually have that more intimate program, but also at the same time you get a glimpse of every single thing. So I mean,
skill set. It's a skill set. I think I found that I got into OR from the day one, while you would find some of my other colleagues, for example, at different bigger name schools, wouldn't get to the OR till like third or fourth year in residency. And it's like, dude, you just wasted 3 years of technical hands-on training, and so I think that made me technically a better surgeon all around. So that's really the benefit. But again, names get you places too. So don't assume that not going to a big name, but it just depends on what your goal is.
No, I mean, that's amazing, because that, like, when you go to a big name school, you have that stereotype. You're like, oh, you're going to get the best of the best. And sometimes those big, like you just said, the big name schools don't allow you to, experience some of these things so you can help you decide what direction you want to go in. And so that leads me to talking about, like, what was it about, cancer or being a breast surgical oncologist that, sparked your interest? Like, what was it? What was it that said, this is where I need to go?
Yeah, so I think I've had several glimpses of breast. I think my first glimpse of breast happened when I was actually in high school, and one of my friend's sisters had developed breast cancer very young, in her 30s, graduated from law school and just got hit with the bomb of breast cancer. And hers was really aggressive. She didn't really last long with the cancer. So that was kind of like first, like, whoa, what's that? I didn't dive into it too much then, because I was still young, trying to figure out what I wanted to do. When I got into residency, though, it was kind of one of those things where I'm a people person, okay? So I like to interact with people, interact with patients. But what I found is if I stuck with just general surgery and that was it, then you tend to do the gallbladders and the appendectomies and remove all these things, and then people are fine, and then they leave. You never see them again until they have another problem. Who knows how long down the line.
Typical.
Right. Me, I still wanted to have the relationship with my patients, know about their life, know about what's going on. And I felt that being a breast surgeon, should I say, kind of put that in light, because you keep track of your patients. You see them regularly. They don't disappear out of your life, and you don't disappear out of their lives. And I think what really drove that home for me was one of my nurse friends who was a really close friend of mine, and we're still friends today. She's actually from Louisiana, by the way. And
Nice,
so I
nice.
met her in Pennsylvania, which is very funny. But she got diagnosed, and I kind of went through this whole with her. I actually went through the whole diagnosis process because she had an abnormal image, a mammogram. I was like, well, I'm just going to go with you to your ultrasound, and then I'm going to go with you to your biopsy, and then I'm going to show up at the surgeon's office and be there for you during your visit, and then I'm going to do your surgery. And so I kind of went through that whole process with her, and we are still in contact constantly throughout, even now. She's always checking in, like, how's it going? Things good? I'm checking on her, like, things are great. And I feel like that's really that well-roundedness that I wanted to be, still involved in people's lives, still helping people day to day. And I found that from my experience with dealing with people that the people I've met in the breast world or in the cancer world have been so grateful for just the little minute things you do, even if it doesn't end the way you want it to end, you know. And
Yeah.
I think that is where I feel like I feel like I have done something, I guess, or I've saved something, or I've changed somebody's life in some way. And that's
I think it's so amazing that, you want to create that safe space, or like you want to know your clients. I know that a lot of times, like even when I was interviewing my oncologist, like some people are like in and out, or until I found the right one. And then you could tell that they are very, very intuitive to what is going on. And it gets like a relationship. Like, it's not just like, hey, how you doing? It's just like, how's your life? How's how's your wife, or whatever the case may be, whatever is pertaining. And so I appreciate that you're that type of doctor, because you don't find too many, this is really like, all right, in and out, in and out. And so what is it like in the day of the life of a breast surgeon?
Some days are easier than others. I hate to say it, but when I'm in the operating room, those are my more calm days. I say calm days because although I'm doing something stressful, ideally, operating isn't stressful. Like I said, it's more of an art for me. So it's kind of like I'm making sure this patient looks good at the end. I'm doing all these things, but I'm actually having the tough conversations that I have to have on my non-operative days, which is one, telling someone they have cancer, that we're going to have all these things, and let me answer all your what ifs, and now I just blowing your mind, and now you're looking at me like I got two heads, and those are much more stressful. Taking on someone's emotions, because sometimes it is emotional. They're trying to hold back tears, and I might let it flow, and because that's how, because I'm like, yeah, I'm like, if you weren't nervous or you weren't scared, if you didn't feel uneasy about it, I would think something's wrong with you. No, I'm just kidding. But it's just, those are more of a stressful day. So, on a day-to-day, I will have younger patients who hopefully don't have cancer sometimes. And I've had my young patients who have had cancer that weren't expecting it to be cancer. And so you're trying to like gauge those conversations. You're trying to read people's face. I think I've gotten very good at being attuned to the non-talkative cues of a patient, to the facial expressions, to the nods, or to the whatever they're doing or they're expressing without actually saying it. I have become very attuned to that over time and throughout even my residency. And I think I'm able to read when they're like uneasy, or when they're thinking something but they're not saying it, or those kind of things.
Right. You can read their thoughts. What was the toughest conversation that you had to overcome with a patient, and how did you turn that frown upside down?
I think, unfortunately, I probably had several tough conversations, but I think one of the hardest ones I have is I've had is a young woman who had just given birth to her sixth child, I guess, and 6 months she'd been dealing with this mass that people thought was just a milk cyst of some kind, because she had just been pregnant. And 6 months, she's like, it's not going away. I don't know what's happening. So when I'm seeing her, I'm just like, well, it could be a milk cyst, but I don't have an ultrasound to like take a look. So I'm like, we can just at least stick a needle in to see what happens, And once I stick the needle, I'm thinking to myself, this is not going to be good, because it didn't have any consistency of what you expect it to be. And you got to tell them that this is very, very highly concerning. I think that we definitely need to make sure this isn't a cancer. And then the face is like, okay, I just had a child, I have 6 kids, I have a husband at home. Lo and behold, she did have cancer, unfortunately. By the time she got to me and me seeing her at that moment, it was already kind of other places. And that became a hard hit for her. And she went through chemo, and I just kind of had to watch her kind of waste away a little bit. And over time, at the end of the day, she didn't make it. I hate to say it, she didn't make it. And that was one of the ones that kind of hurt your heart, because you kind of feel like I could have done something if I had just known about what was happening to you sooner. That's where education becomes a big push for me. just educating patients, physicians themselves as well. But, if the patient requests it and they're fighting for themselves, they're going to be the best person to fight for themselves, whether the physician's knowledgeable or not.
Yeah.
That was a tough one to kind of get through. And, I even found out today that one of my patients I just saw a couple weeks ago was on chemo, her cancer progressed, and now she's going home with hospice. And so it's, and she was so excited that, that we were kind of making headway, and then it kind of just turned left real fast. And so, you find out the ones that the hard fights aren't always won. And those are the ones that I think stick with you the most. Obviously, the ones that win and do great are awesome too. But, I think you keep those ones in the back of your mind. Those are the constant humbleness that I receive on a day-to-day, not day-to-day, thankfully, but, I guess when it's necessary. But
when do you think is the good time to get that second opinion? Like, do you also offer that, say, hey, you should get a second opinion, but when is a good time to do that?
I think it's a good time if somebody feels uneasy or uncomfortable, or a lot of times second opinions come about because someone's hearing something they don't want to hear.
Yeah.
But I think the second opinion solidifies that what they're hearing is correct. So
Yes.
if someone's having a tough time with something that I'm telling them because they think there could be a different way when I know there really is no other way, then get a second opinion, because then you'll understand that I'm not coming from a place where this is what I want to be doing to you, or this is where I want you to be. I'm coming from a place where this is the best treatment for you. I also think a second opinion is warranted when there are things that are out of my capabilities. So example would be, we don't have a big, robust clinical trials at my hospital right now. We're working on that. It's a big work in progress, and I think we're getting better. But there's certain trials that we just don't have that I think some people are candidates for, because we can only do so much where we are. So those are those, more aggressive tumors and the more aggressive cancers. But that is really a point to say, really, we need to get you in these trials. We need to go to these bigger institutions or MD Andersons or what have you to get into these trials that we think will actually work, at least prolong, life or what have you. And so those are when I definitely segue out. And I never tell a patient they shouldn't get one. Ask me, by all means, do what you got to do. I'm right here. If you want to get your care with your second opinion, does not bother me. If you want to stay with me after, I'm okay with that. And I think that really makes them feel comfortable. And most times they end up coming back, because usually it's for something that I know is going to be straightforward. And they're like, oh, well, they said the same thing. It's all good,
Right. Now you said something that just sparked my interest, and then I'm big on is like, and it's about being knowledgeable about like what's going on with your body and even what is to come. Why do you think people are afraid to like really understand what's going on with their bodies or their diagnosis?
Honestly, that is always the one thing that always kind of throws me for a loop sometime. It's one of those things where people just, I don't know if it's just a control thing sometimes, where they have to control this part, and they really can't, because unfortunately the cancer does what it wants, and you can give it your best fight in certain areas, but you can't ignore it forever, because it's going to just keep doing what it's going to do, because it does not know doesn't have a mind, does not work that way. But I find that it's an education factor for a lot of people, that if they think they ignore it, that it's going to go away, and so to me that becomes not a knowledge thing. It's just more of a out of sight, out of mind, when it becomes no longer out of sight, out of mind. And again, for example, I can tell you a patient that I saw recently that some kind of tumor on the breast about this big. Next thing you know, it's about this big. And I'm seeing them, and I'm like, and it smells. And I'm like, okay, so you've been going around life and going around people with this smelly, funky thingy on your breast. And it's just like, but it's been a year. So I'm like, so what position to get treatment versus, and so those conversations are very hard, because you kind of know something's wrong, and they know something's wrong, but it's just more of a denial thing. But when it comes to education about things like the lady who had the milk cyst, I always say, always err on the side of caution. Is when I go out and give speeches to people, I'm like, err on the side of caution. If you don't think it's normal, get it looked at.
Yeah.
And that doesn't mean get it looked at by the physician by an exam. That means take an image of it some way. So if that's an ultrasound or a mammogram or whatever, request one. If your doctor is saying no, it's probably this, and you say, well, I want to know if it's really probably that. Go ahead and get it. But you have to be aggressive, because sometimes they're going to assume it's this, and especially if you're in that 30s to 45 range, where you think, okay, I have a baby, I'm having these little milk things, but you're in that range where cancer still actually can exist, even if you're less than the age 50, just, and so, and I've had, like I said, I've had a young 31-year-old come in who's a resident, and she had a little mass, and she thinks, oh, well, maybe it's nothing, but I'm just going to check it out. Thank God we checked it out, because I was kind of like, that is not,
Yeah.
and then
Now,
lo and behold, cancer at 31, and so it's just
do you see that it's a difference in the, Caucasian white versus the Black as far as your experience, or like them asking more questions, or just like, what is that? How is that like night and day? No pun intended, but night and day. What is that experience like?
It is, because you'll find, and the Caucasian women tend to be more educated. They've gone and researched. They've probably read something and whatnot. The Black women tend to be a little bit more not trusting in medicine, which we understand has been ingrained in us from some times and years, that we're out to kind of get them or something. Which is, I understand where that thought comes from. But it tends to be more on the level where, I have someone tell me, well, I'm just going to let God do his thing. And I'm like, well, did you ever think that God put you here in front of a specialist to help you take care of this thing?
Yeah.
I think I've learned to have to make that adjustment when I'm talking to somebody about that, because it's like, God puts you in places, doesn't necessarily handle things just directly for you, but they put you in front of people who are going to help you get to the place you need to be. And so therefore, that's why I'm here, because this is what I do for a living all day, every day. So he brought you to the best person he thought was capable to handle this problem.
Exactly.
Just not doing anything is not what he had in mind, and that's kind of how I'm able to break through that barrier of something. There's times where it's just like, well, I have to do this. I couldn't get off of work, and this, and I completely understand that, because one day off of work is a paycheck that maybe your light bill just didn't get paid, right? So That's a whole different paradigm of issues, and then maybe I don't have a ride, so I got to catch 2 buses to get down the street to get to the hospital that has to take care of, but who wants to take that time? And then if I miss the bus, I can't get back home. And then so there's a lot of other outlying issues that make that harder for a lot of, say, African-American women and men in general, because it's just access, trying to get to places and what you're doing. And if you don't have that, the insurance, and you're trying, so that's why I work at 2 hospitals. I work at the community hospital that's there for our indigent, our self-pays, our people who don't have the money to fund. And I work at the main hospital, I guess, where you have, but it's just because I need to make sure that we're taken care of in some way, shape, or form, and that we get the appropriate care.
So, of course, you don't see this often, which is males that have breast cancer. Have you interacted with some men that had breast cancer, and what, as men, like, what should I be looking out for? Because it's rare, it's not as common. They don't talk about it, but like, how was that experience with those men that had breast cancer?
Yeah, so usually I find that the men that end up developing breast cancer usually have been treated for something else, something like prostate cancer, where they've been given some kind of hormone after the fact, and then they've developed more fatty tissue around their chest. So then after a while, I think what happens is that people start to think, okay, well, they have redness in the breast, they must have an infection. And so it gets played off like it's an infection, but theoretically it's probably cancer brewing in the skin that we don't know. So I've had that situation happen where someone went in, they cut in everything, and they're like, wait a minute, this is not right,
Oh, wow.
And then, so it's not as on the radar, I guess. And so I think whenever someone comes up with the issue of mass or anything, it could just be normal breast tissue, but I think it's warranted to make sure that we do some kind of imaging, like I said before, to make sure it's not something more serious. And especially if that person is on some kind of hormone that's going to drive the same drive it drives in a woman. Okay, so I just tell people, if you feel a mass that was not present there before underneath the nipple area, or if you feel something hard, if you see the skin being pulled in, or if your nipple is pointing out but it's now being pulled in, the same thing exists for men. The same thing can happen. You feel a dimple in the skin, you feel a change, you feel some dryness on the skin, like any kind of thing that's not normal, that hasn't been present all your life, is not normal. And then make sure that it's not going to be something that's going to kill you, and that's kind of how I approach that. And we treat right now men the same as women, but again, it's just I'm sure as time goes on that will change. I mean, I definitely have an abundance of men patients that I've had to take to the operating room and do surgery on. So
what is the BRCA gene? What is that?
So the BRCA is the breast-related cancer gene, and they have a couple different. They have 1 and 2. So essentially, what it is that it's a DNA, problem, or an issue where you have something wrong with your DNA, essentially, and that DNA gets handed down from family member to family member over time. It can be passed down from a man, by the way, to the daughter, or from a mother
Wow.
to a daughter, or from a mom to a son, or for, so it doesn't have, it's not gendered in the sense of the word. So that's why I think that's the misconception, that people think it's just only the females passing it down to the female. That's not really how it works. It actually can get it from a man or the mom. And so what it does is it increases someone's risk of a lot of breast cancer, of course. If you have one or two, you can have increased risk for things like prostate cancer if somebody has that, right, as a male. And there's also increased for ovarian. And then 2 has a couple more other things involved in it. So whenever I'm doing a history, I ask patients all their history, not just breast. I like to know if they have breast and ovarian, because those are the 2 obviously associated with. But then there's cancer, there's pancreas cancer, there's prostate cancer, there's melanoma, there's stomach cancer. So there's a lot of different genes. It's probably about 8 actually that will increase your risk for breast cancer, but also increase your risk for other things. And therefore, you should not only be surveilled for your breast, but you should probably be getting colonoscopies and EGDs and all these other things done to make sure you don't get some other cancer that you are at high risk for. But the BRCA is the one that's most noticed for breast cancer these days. But we have a lot of patients with varying degrees of different mutations that will increase their risk of breast cancer. And that's what brought it to the forefront, but they're associated with other things.
Wow. Wow. I'm going to switch gears. Now, you're familiar with Dr. Green and the Orally Foundation a little bit, are you?
Mm-hmm.
What do you think about the things that she's doing in that technology, and why it's not, no one is like, coming out there and just helping her, get this out there?
I think we should be, just the knowledge and once you get all these trials done, you get a good conglomerate of patients, and you say to yourself, okay, these patients are rocking it out. We're curing people. We're not doing that. I think that's when it becomes alive. I feel like it takes years. Like, so for example, I give people examples. Like, well, the way I treat people is probably not what you would go read in a book, because what you read in a book, before it gets in the book, it takes 5-10 years before it ends up in that book.
Right.
And so what I'm doing is, because I'm sitting at the forefront of it, because I go to all the meetings and I'm up to date of the newest things that may not be printed yet. But the rest of the world, they don't even see it until it's printed somewhere, and it's usually 5 or 10 years down the line. I hate to say it, but it takes that long. And it's interesting because I have these conversations with the residents that I teach, and they're like, well, book answer on your test is to do this. However, the way I'm going to treat this patient is like this, and I let the patient know it's not also written in stone. It's outside the paradigm, but we equate this data that we know over here that's not published to the data over here. You know what I'm saying? So I think that it's one of those things to understand, like, that's just kind of how it's a delay. It's always a little bit of a delay when it comes to research studies and what's new. Yeah, I mean.
Okay. Yeah, because I mean, like, we have our national partnership with her, and we support her, and so I'm glad that you're a fellow doctor, and you're like, yes, you are in support of that, because sometimes you can't be so textbook. You know what I mean? Like, if you're so textbook, you're never going to see outside of that focal vision. So that's pretty dope. So I know you talked about this. You do you work at 2 hospitals in the community hospital. What is that experience like at that other hospital for those patients or those survivors at the other hospital? What does that experience look like?
The community hospitals?
Yes.
Yeah, so it's a little bit different because I often have to find myself trying to tailor treatments so that people can get what they need without feeling like we're breaking their banks, and that we're not. We don't want to limit their access to the same type of treatments. So, I think I got to that hospital in late 2017, and it took a while to kind of figure out the nature and the culture of the environment of the hospital, I think, a little bit, and then trying to make the changes. So when I first got there, it would to get a diagnosis, which is really like just screening, but something's wrong. So it takes you 2 months to come back in to get your diagnostic, and then it takes you another 2 months to get your biopsy, and then it takes you. So it was this whole like drawn out process that I was kind of like, we need to fine tune that just a little bit. So then as I got there, we started taking on the role of looking at things and streamlining them, and then educating our family physicians and our internal medicine physicians to say, okay, you get this study, you need to get this done. You don't have to wait for them to come see us, because they used to just send everybody to the surgery clinic, and then we had to go decipher, but we couldn't get everybody in tomorrow, right? So There's a lot of things that had to be changed in that culture, and I think I was able to bring upon a breast-trained radiologist into that hospital. that will work with me, Tana, because we're both, fellowship trained specifically in breast, and that's all that we do. And that has helped us together streamline that process. And these patients have definitely gotten better, faster, swifter care, should I say, being just from that process. But also it's just providing them with educational material. So I created a breast education binder that has as much information as they need with surgeries, about their cancers, risk, benefits, disadvantages, oncology, like all these nuances, exercises after surgery that they can take home with them and read through and have something to look at, because not everybody's going to go on the internet and everybody's going to do all those kind of things. And so for that community, I brought that over to them to utilize to help educate them, because they don't go on the internet as much as my Caucasian patients. And so it's one of those things where what can I provide to the community that will help them educate themselves about their cancer, and then come back with the appropriate questions. So those are just some of the things that you encounter.
About how many people, come in and out of the community center? Like, how many people do you kind of like serve, of the month?
Yeah, so I go to the clinic there every Thursday afternoon, and we can see about 20 patients each during 12 to 2. It's pretty high impact patient care there, because I'm only there half a day a week. And then I actually do operations there on Wednesdays. So I operate there on Wednesdays, and I see patients Thursday afternoons. And so it's kind of like putting that into the fold. We're now starting to work on a little bit more of a high risk screen, because that's become a very big thing where people want to know what their risk factors are. They should be taking extra precautions. Should they be getting extra imaging? Should they get genetic testing done? But again, taking that on is going to be another role, because they don't necessarily have access to pay for an MRI that can cost them $6,000, but do they have $6,000? No, right? So how do you take care of that? And who has $6,000 anyway? But exactly. So I think it's a big deal to just say, okay, well, now you need extra imaging, but we can't afford to give it to you can't afford to do it. So that's kind of some of the things that we struggle with. But we do see quite a bit of patients just from breast through there, and sometimes we've gotten up to 25 patients in a short afternoon of patients.
Wow. So how has COVID affected that?
Yeah.
Because has it been like maybe half, or how did y'all have to adjust with COVID now?
Well, so COVID, everything came to like a hard standstill. I can tell you what happened. Hard standstill until people could figure out what we were gonna do. So initially, like, everything shut down, closed, and I'm like, hold up, cancer patients still need to be seen and talked to. So then, the good thing about like the American Society of Breast Surgeons and the Society of Surgical Oncology and the American College of Surgeons is that they hopped on COVID like they were probably the fastest societies to get criteria and protocols like up.
Yeah.
Because, that is really where it was going to be important, right? Because when it comes to like family medicine, they would have been able to just do telemedicines and things. But for us, it was like we were holding people's surgeries. People got cancer, and you're like, "What, you're not operating on me today?" Like, well, your cancer's not growing that fast, And then it made a shift how we did things. But for me, I definitely made sure that we saw our cancer patients. I didn't really push them to the back burner per se. Anybody with a new diagnosis, if it was somebody that I felt like I had needed to see personally and physically, I just had to take the risk, because I needed to tell you about yourself from the camera. Like, I need to actually feel and see. But certain things I knew would be okay, and I would call them and let them know what's going on, what the plans of action were going to be, and that we're going to put you on this to keep the cancer kind of for this time being, until we kind of get to this phase of like everything on hold, no elective surgeries, nothing. Like nothing to do that was elective. And they considered, can certain cancers of the breast wait 3 months? Yeah, absolutely. Without having any problems or any changes? Absolutely. That's why it became, okay, well, who can get surgery and who can't? So what is going to, and then the other issue was like, okay, we're going to give you chemo. So the patient's like, I'm going to give you chemo during COVID? Do I need it? And I'm like, like, aren't I going to start COVID? And so that was, it was pretty tough, actually, to kind of have those conversations. And people were like, so then I had to keep track of like who, once they let me start to do surgeries, who I needed to put on the surgical schedule for. And it was like the catch-up game was pretty difficult. I was operating 4 days a week, operating 3, but I was seeing patients all 5 days of the week throughout those operating days. So it was very thick, heavy. But it was because I knew that people were waiting, and I needed to make the extra sacrifice to make sure that they got in, not out there waiting with the cancer in their body.
I salute you, man. Like just hearing it, as you see, I'm smiling, because it's like you are doing the work, but also too, you're making it happen, and you're adjusting, and it's so awesome. Like, so if I'm a man or a woman that needs to do prevention, what are some tips and things that I need to be myself or just any other woman that's listening to this right now need to be aware of when it comes to breast cancer prevention?
So things that you can't control is what I call them. Things you can't control are weight. So the goal is to maintain a healthy weight. The more fat you have, the more fat cells produce estrogen and progesterone. And most of the breast cancers that we see are sensitive to that.
Okay.
Not necessarily cause, but what I tell people is weight is a cause, but reality is that it just feeds the cancer to grow. So maintaining healthy weight is always something that we can control. I also tell people just being active. Exercising. We tell people about 30 minutes a day, 5 days a week is probably a good idea, a standard, steady way to do that. Limiting alcohol intake, which has been hard in Corona, I could tell you, because most people have alcohol like it's nobody's business. But you want to limit the amount of alcohol that you take in, because we do know that there is some association with having 3 or more glasses a day of some kind of alcohol beverage can actually increase that risk of breast cancer. And I think it's more related to the liver, because the liver actually can produce estrogen as well.
Wow.
And then obviously trying to prevent, it's going to be hard to control things such as being a woman. Being a woman automatically is going to put you at risk because you are a woman, and that is just it. And then early detection is all we have right now. As far as, trying to find things as early as possible. We start to dabble in this thing called chemo prevention, which is not chemo. It's actually taking a pill to help lower the risk that cancer occurs, but it's best for people who are a BRCA or a BRCA gene mutation. Yeah. They're at about 65% risk, lifetime risk for developing breast cancer. So you're trying to lower that risk. But we always talk about healthy lifestyle, mammograms, physical exams. We do not necessarily endorse monthly self-breast exams anymore. What we really endorse is knowing your breast. So that means you should be familiar with what your breasts feel like, but you should know if something has changed. So the only way you get familiar is to be aware of what they feel like before they change. And so that's where we just say you really want to still examine the breasts, because a lot of times women find their own issues and problems and bring them to the forefront. Yeah. But reality is, being healthy is just the best way to overall for your body, but it doesn't necessarily mean you're going to prevent what's going to happen.
So I'm going to ask you this because, I watch Grey's Anatomy, I watch Doctor Strange, and do you have like a ritual, or before you go into like surgery, do you like prep your mind? Do you play certain music, or you just like, nah, I just need to get this done? Like, do you have like your own little thing before you go into the room?
I do wear really cool hats, like I like to just say, okay, what's going to match my, I'm a more of like, I wore this color scrub today, I'm going to put this hat on. I have a Superwoman hat. I got like all kinds of different.
Okay.
So I do put those kind of things on, but as far as like the preparation for me is usually making sure the patient has everything they need to get done before we got to the operating room, to make sure I have all the things, that equipment that I need at the side, make sure that if I have a portable ultrasound that I carry on my, like a sling, and hook it to my phone if I need to. So that's always around. And I'm able to just ultrasound with my phone. People are like, whoa, I'm like, new technology is great. That's been amazing.
Oh, wow.
So when I go to if I go to the hospital inpatient, I don't have to go around for one of those rolling machines. I literally just pull it out my bag and I'm like seeing what's going on. So I'm always prepared for the potentials of things not going the way you always plan them. But I think for me, I'm pretty calm and cool and keeled when I'm in the operating room. So if there's an issue or problem, I don't really fluster pretty easily. So it's just, I take it as
like that. You said I got a Superwoman hat. I got the portable ultrasound. That's it's so convenient though, because you're waiting for a nurse to bring a machine, and you be like, okay, let me get this done. Let me.
They don't know where it is half the time. I can tell you. They're like, where is it? I'm like, okay, never mind.
What do you like most about your specialty? Like your practice.
I think my specialty has an amazing group of people who rally behind their patients. We do a lot of things that we hope make the experience better for patients. So, the group of surgeons, men, who go to our society meetings, who are trying to do things for the betterment of the patient, to, we've gone from what we call that the radical mastectomy, where we used to just chop people's breasts, their muscle, everything, and all their rib cages would be exposed. And we've gone from such radical deforming surgeries to be thinking about women, men for that matter, as a person, where what you do could be disfiguring, and so they shouldn't have to be wearing that disfigurement every day. And so I think we have progressed. I'm starting to see the tides of the insurance companies change for patients who decide, okay, I don't want to have both breasts. I don't want to have to go through mammograms and ultrasounds and this and that every time because it brings me so much anxiety. It used to be a struggle for a patient to say, well, I have cancer, how can I get this one removed? And I'm not saying that's always the right answer. Some people think that's overkill, but it's at the same time, it's the person's choice. I think it's a choice to say, I don't want to go through a mammogram every time I have to go through a mammogram. And in my mind is thinking, oh my God, what's going to, from mammogram, that's every year, right? So, or I have to get this MRI done, or they're going to find something and bring me back. And so that can create a lot of anxiety in people. And then, well, let's say someone has a 44 double D breast, but you're going to do a mastectomy on one side, but they still have that 44 double D, like, yes, they pay for reductions, but why can't we just make them flat and then they both be flat and that's how they want to go, So there is just, the insurance company finally starting to catch up to the fact that, yes, does it make sense to them? No. But does it make sense to the patient? Yes. So, you're going to pay for the reduction on the other side, but you don't want them to get a mastectomy. So like, it's kind of one of those things where I'm just like, if they have to get an adjustment to this breast, why can't it just be a mastectomy?
So you said insurance, and insurance is huge. How is there a special type of insurance folks should have, or just having insurance that can cover these big ticket items? Because I know for myself, I was blessed. Thank you, Wells Fargo, because when I saw the breakdowns and I had my deductible, and I said I would be more than happy to pay that deductible than
instead of all the other stuff.
Like, how important it is to have insurance, and how many people come in there without insurance?
So it's very important to have insurance, especially when you get a diagnosis of cancer. I hate to say it, but who could predict that? That's the other problem with that. But the ones who don't have insurance, it could be a little tough. I think we do have programs in place. We find the money. There are grants, Louisiana has grants throughout the state that let us do certain things, screening mammograms.
Yeah.
The patients can apply for, special funds. We call it free care, to help them get the treatments and stuff that they need without paying up the wazoo. And we have payment plans. I mean, all those kind of things. It's easier to have insurance, although it can still be a big burden of out-of-pocket costs if depending on if you have the high deductible or low deductible plan. All that stuff matters. And I often tell people, the best advantage you can do is if your company has a health savings fund or something like that, and you're going to be getting certain things that are going to cost you out-of-pocket cost, put it in your free savings plan, because what it's going to do is, one, it's going to help your taxes. So at least it comes out pre-tax.
Yep.
And you may be able to recoup some of that money, but then when it comes to paying that bill, you've already set the money aside already over months of time, versus a large lump sum coming out when you're not ready to expect it, or you don't want to give it, what's going on. So that's one way I try to, segue people into savings, but try to spend it into a way to at least give you some tax break or something that you're going to use it. If you know you're going to use it, put it in it. People don't know they're going to use it, so they're not prepared. But I will tell them, we can wait the year for you to kind of recoup that, to do this additional to do this additional imaging. When you're probably not going to affect that. But let's put that $6,000 that you're going to have to pay out of pocket for this MRI out of your fund, so that and then we'll do it towards the mid to half a year where you already recouped that, and now you can just pay with what you've already, and you're not losing the money outright.
Exactly.
So I do a lot of coaching that, like, as if I know what I'm talking about, but I mean, I just learned this stuff over time. I'm like, man, this is, expensive. And I try to shop around. So this MRI place is much cheaper because it's not a part of the hospital. So you might want to go to this MRI, it's like, I find that out on purpose, because these things that we want to do to help better detect cancer can be expensive.
Exactly.
Or to treat cancer can be, some of the, I don't know if you ever looked, yes, you probably have, the amount it costs to get one bag of chemo, depending on the chemo, be like, wait, is that $60,000? That's a whole car. That's a whole real nice car, and it's like, hold up, And so it's like, if you had to pay the $60,000, you'd be looking at people like, I guess I'm gonna be dying today,
Exactly.
Because,
just the hospital, just 3 days in the hospital alone is like almost like $250,000.
Is crazy. So I'm just like, it's not for the faint of heart to not be prepared with insurance. And again, we do things in the community to help those who do not have insurance.
Yeah. Thank you so much for that. So we have a section here where we give our positive deposits, but with you, I have a little different challenge for you. So I want you to give your top 3 prevention tips for men and women. And then I want you to give the positive deposits, those words of encouragement or those strategies that will help any survivor, any med student that is, wanting to go down this road. And then that's a wrap, that's a wrap. So I need 6. So I'm giving you 6. So
all right, let me see.
3 prevention, then your 3 positive deposits, and then we'll talk about how people can reach out to you and get in contact with you.
So my 3 preventions. My first prevention is this: know your family history and make your family speak, because there is prevention in that, because we can actually determine risk and maybe help you lower it before it even ever hits or exists. That's number 1. Yes. Number 2, maintain a healthy lifestyle as best you can, and that means be active. That means maintaining healthy weight and eating better. And tip number 3 for prevention, unfortunately, I gotta say drink less. Although it's very hard to do. So number 3, 3, but mainly the top 2 are the most important, to be honest with you. Then positive deposits. Let's see. For survivors, recognize that you become a survivor from the day you're diagnosed. It does not start the day you beat it. It's the day that you were diagnosed, because you're beating it from that day onward. And stay positive. Yeah. That is what I would say. Positive. Always stay positive. Always stay active, and keep doing the things you want to do, because that is how you get through things far better. For my other positive deposit, I would say for the students, I do a lot of work with our LSU students, and it's always hard to figure out what you want to do in life, because you're only exposed to a portion of what medicine has to offer. But the advice I've given to a couple students recently was, if you're at a place where you are surrounded by several different specialties and you haven't had much interaction with any of them, when you have downtime, reach out to those specialties. Because if you're at a place where they allow students, then they're going to be receptive to you speaking to them about their specialties. So we don't get a lot of exposure to head and neck sometimes, which is ENT. You don't get a lot of exposure to the surgical oncology side, although general surgery does sometimes involve that. You may not get as much exposure to ophthalmology of the eyes. But if you have that exposure on your campus, reach out to those individuals that you see on the board or the surgery board, or that you see, and see if you can contact them and say, hey, I'm just curious about your specialty. What is it that you do, and what do you like about it? Because you need to take those opportunities to do and figure out what you want to do, but it doesn't have to always be the standard track. Yep. My third deposit is probably for those up and coming physicians getting ready to graduate from their programs in schools. We're going to have a shortage of primary care physicians. We're going to have shortage of pretty much every physician in the world, but the biggest brunt of the primary care docs. And unfortunately, they take a lot of the heat and get less of the pay. It just, unfortunately, how the cookies crumbled, but we still need champions in the community helping people get better on the healthy level, not just the surgical level or any of those specialty levels. But stay positive about that. Try to find ways to become efficient in your job, to make your job better. When we have these medical electronic records that take up all of our time, there are ways to become efficient. Figure it out so you can still enjoy your job. And that's what I would try to, I do that every day, rearrange, try to make sure that, but me, I'm not as worried about getting my notes done. I get to work at 6 o'clock in the morning to give myself 2 hours to get my notes done, or I'm up till 10 o'clock at night. But the point is not to make the patient wait in my office. So I don't sit around typing my notes with my patients in the office. If I can't get the note done between time, I keep it moving, because the patient shouldn't be waiting in the waiting room forever. That's not how, I don't like that. And I also don't like to type my note while the patient's in the room, because I like to look them in the face. So I don't get on the computer, although we have computers in my room. I usually am sitting directly in front of the patient on a stool and just literally looking them in the face when I'm talking to them about anything. It doesn't have to even be cancer, but I don't feel that I like to keep my eyes and head turned that's just not me. So if I have to take the brunt of the after before situation and get notes done outside, it is what it is. But everybody has their own process. And for me, it's always patient first. Everything else is just a secondary situation. But I understand that you do have to get these things done, especially if you see 40 patients a day. So, and our medical professionals do see more patients a day. I spend an hour talking to my cancer patients so that they get an hour chunk of my time. So that's just kind of how that process works.
Well, Dr. Grisby, you done dropped some Mean knowledge. I love the prevention tips and just your positive deposits that you dropped on us. So if folks want to reach out to you and kind of, have more questions or just follow what you're doing, how can we reach you on your social medias?
So on Instagram, I am Shaunda, which is ShaundaKG. And on Facebook, it's just Shaunda Grisby. I'm usually able to be found that way. I have a personal and I have a medical side. So either way, you can find me.
Either way, you're gonna get this great knowledge. And so I'm so grateful and thank you and honored to have you on here. Like this was amazing. This was amazing. And so for those that are tuning in, you can catch this on our website, www.positivedeposits.org. That donate button is very active. So please support. We're on all streaming platforms, Apple, Google, Spotify, and iHeartRadio. So you can't miss us. And so we are glad that you tuned in. And of course, we are here to transform minds, to change lives. And we'll see you next time.